Hello guys, welcome to the Parson series, and in this session we will be looking at the inflammatory aspects of the retinal diseases. So in this aspect we will first start with the Coats disease. We have already seen the vascular diseases. Now this is one aspect which is involving both the vessels as well as inflammations, or bridge between the vascular and the inflammatory pathologies. This is presenting a characteristic monocular ophthalmoscopic picture usually seen in boys, and this is unilateral. So unilateral seen in boys, large raised yellowish white area of exudation, and we can even have smaller areas posterior to the vessels. Detachment of the retina, we have cataract or glaucoma may occur, and there is always microscopic evidence of hemorrhages between the retina and the choroid and in the deeper layers of the retina. So actually what is happening in this Coats disease, whenever you are thinking about the Coats disease, always remember that it is basically idiopathic. We do not know the exact cause of this Coats disease, and it is a vascular disease, but it is the inflammatory pathology of the vessel. So it is the idiopathic vascular telangiectasia. Idiopathic vascular telangiectasia we have got inflammation in the vessels, and it is common in the boys. It is unilateral, and these boys are usually in the first decade. This will be found in the first decade, and these kind of boys will have lot of inflammation. So lot of inflammation means a lot of exudation, and due to this lot of exudation, the type of RD that we are getting is the exudative RD. So it is one of the important causes of the exudative RD. Because of the inflammation, you can have secondary inflammatory glaucomas. Due to the inflammation, we can have complicated cataracts. So you do have the cataracts, you have the detachments, you have got the glaucomas, and you have got the hemorrhages also. Now the ophthalmoscopic appearance is usually characterized by a number of small aneurysms. We have got exudation along with the masses of the cholesterol crystals. Now choroid is at first healthy, but you can be reminded of the choroidal angiomatosis, because sometimes you are also having the similar picture in the choroidal angiomas. Early recognition followed by the prophylactic laser or cryotherapy may be beneficial, and because it is having the telangiectasias, it is actually idiopathic vascular telangiectasias, inflammatory malformations that you are finding in the vessels. Due to that, you have got lot many things. We have got secondary cataract, secondary glaucoma. Now here secondary cataract does not mean the posterior capsular opacification, I mean to say, which is secondary to the ocular complication. So it is a complicated one. The exudative RD is also there, and due to a lot of exudation, it is also the DD of the leukocoria. You are also having a lot of whitish pupillary reflex, that is leukocoria here. So whenever they are talking about the whitish pupillary reflex or leukocoria, and that too unilateral, think about this. Okay, one of the important causes of leukocoria in children is actually the congenital cataract. Then you have so many things. ROP is there, Coats disease, retinoblastoma, endophthalmitis, toxochariosis, all these things are there, and depending upon the other things that are present in the question, you will have to follow the rule. Okay, now we have got this is a Coats disease, and if you look at the picture here, we are having the subretinal exudation also, and the angiomatosis. So the diagnosis actually is not merely based on this, because you know, this kind of fundus finding you could be finding in other places also. So certainly you have to look at the age of the patient, the gender of the patient, the other cataract, glaucoma, all these things you have to look along with the leukocoria, and then you can make the diagnosis. All right. Now talking about an important aspect, that is your medical therapy in the retinal vascular diseases. Now in the previous sessions we have already seen the retinal vascular diseases. What is the medical treatment that we are going to give? So retinal ischemia commonly occurs in retinal diseases like we have diabetic retinopathy, retinal venous occlusions. We have the ischemia there that can lead to the development of NVD or NVE together with the macular edema. So if you think about the retinal vascular diseases, let's think about the diabetic retinopathy per se, so that you are able to correlate. So I will have the neovascularization. That neovascularization is on the optic disc elsewhere, and then we also have macular edema. Then development of new vessels is also found in ARMD. The wet ARMD is also there, or we have got the retinopathy of prematurity. So all these diseases are having something in common, that is neovascularization or the fibrovascular proliferation. So the what is a treatment, standard treatment. So photocoagulation remains a standard treatment of choice but has a frequent adverse effects. So we have got certain what you called as the pro-angiogenic factors. These are actually released in response of this ischemic environment, and the main one is your VEGF, vascular endothelial growth factor. The adjunctive modes of inhibiting this allows a greater success. So we are giving a lot of anti-VEGF agents. So what they want to say that whenever we have got the vascular diseases and they are having ischemia, a lot of factors are released. Okay, one important one is the VEGF, and therefore the treatment modality, as far as the treatment modality is concerned, one important treatment modality which is common to these is your anti-VEGF. So we have got the PEGAP, tandem Acugen, bevacizumab, Avastin, ranibizumab, Lucentis, and then we also have the aflibercept, that is Eylea. They have been developed, and they are used as a successful treatment in cases of the neovascular ARMD as well as the diabetic retinopathy. Alright. Now, if you talk about the second thing, that is your steroids. So, steroids can obviously downregulate the inflammatory stimuli. They are modulating the response of the VEGF gene, and these antigens are present on the human RPE. They may hence play a role in reducing the edema. If I talk about these steroid in specific, we are using the triamcinolone. In the intravitreal dose of 1, 2 or 4 milligram have been evaluated for the diabetic retinopathy, cystoid macular edema, venous occlusion, Zeil's disease. We also have the implants. We have got the intravitreal implants are there. They are containing dexamethasone or fluocinolone. They are also commercially available. Now, what you have to remember is that which are the drugs that we can give by the intravitreal route, right? Then what is the name of that drug? What are the doses of that drug? Are there any implants there? So we have got the sustained release implants also there, and these sustained release implants contains the dexamethasone and fluocinolone. They are also commercially available. So these are the newer aspects of the anti-VEGF treatment, because anti-VEGF treatment in itself is also a newer thing. So if you know these things about the treatment, it will be easier for you to follow certain options of the questions. Alright. Now we start with the inflammation of the retina per se. Now, if you go with the inflammation of the retina, that is your retinitis, most of the inflammations are associated with concurrent inflammation of the choroid. So, it is chorioretinitis. Now, if you remember your posterior uveitis, chorioretinitis, most of the places when you have retinitis, you have also choroidal involvement, because choroid is actually giving the nutrition to the outer layers of the retina, and they can be divided into purulent inflammations by the pyogenic organisms, or they could be specific infections. And most of the cases when you are having the retinitis, you have to actually treat the systemic condition, the general condition. Alright. So first let's start with the purulent retinitis. It can be acute or it can be subacute. The acute forms are due to the lodgement of the organisms, and that lead to the metastatic endophthalmitis or the panophthalmitis. So when we have the purulent retinitis, what is happening? We are having the pymia. Pymia means the pus, and that is lodging. So metastatic means there is a lodgement of these organisms which will be causing either endophthalmitis, or it is involving the sclera also, that will be causing panophthalmitis. Now the other one is your subacute infective retinitis, septic retinitis of Roth. So they are talking about the subacute bacterial endocarditis, where you have the rod spots. They occur in less virulent organisms, typically in the bacterial endocarditis and the purpural septicemia. So most of the times they are asking you the subacute bacterial endocarditis as a cause of the rod spots, but one more is there. We have got the purpural septicemias. The posterior part of the fundus is affected. You have got a lot of recurrent hemorrhages, and as I told you, we have got a whitish dot in the center, and that is actually your fibrin clot. The characteristic feature is a round or oval white spots, rod spots, and some amount of edema or papilledema may also occur, but the disease is frequently fatal, and the vision may be seriously impaired before death. So this is again a very severe disease, because not only subacute bacterial endocarditis is a severe disease, the rod spots that are occurring are also very fatal in terms of the visual impairment. So if you remember, the rod spots are found in this question, that rod spots are actually found in the subacute bacterial endocarditis. This was once a question in NEET 2018. So again, this is an important question, and this is one question where you can get a clinical integrated question in ophthalmology along with the medicine, along with the maybe micro about the organism and all, and they can be asking you about the rod spots or ischemia or about the treatment in any of the forms they can ask you. Then other thing that we will talk about is your anaphthalitis. Anaphthalitis, that means infection, and it's obviously very serious, and as I always say, anaphthalitis is the end of the vision, so it's a very severe disease. We have got loss of vision. This usually occurs after the intraocular surgery, or it could be a penetrating trauma. Now usually, you know, endophthalmitis can occur after anything, but usually when we think clinically about the endophthalmitis, you have to think two things: either there is a surgery, and that is a surgical trauma, intraocular surgery, or it could be a real trauma. So the real trauma it is more the penetrating injury which is leading to the endophthalmitis, and you can give the antibiotics that can be given intravenously. We can also give the eye drops, the periocular injections, the intravitreal injections. So means when there is endophthalmitis, you have to start giving the antibiotics by all the routes. In the end, if the endophthalmitis is severe and it is not responding, then you have to give the vitrectomy to remove the infectious material inside the eye, decrease the blood bacterial load, allow the antibiotics to go. Visual prognosis is always guarded if the endophthalmitis is occurring, that is always there. Alright. Then talking about the acute retinal necrosis, that is your ARN syndrome. Now the disease is characterized by blurred vision. We have panuveitis, we have got whitening of the peripheral retina. When you hear the word necrosis, obviously it will lead to whitening. So we have got the necrosis of the retina, that is why we will have the blurring of vision, right? The necrosis obviously will take place after the inflammation. So we have blurring of vision. If you look at these things, we have panuveitis, and due to uveitis we have necrosis, and necrosis will lead to whitening. And sometimes the posterior retina is multifocal and convalescent, and you can get the retinal hemorrhages, vasculitis, and this retinitis, the hemorrhages, the vasculitis, necrosis, this is occurring in the both central artery as well as vein. 2/3 of the cases are unilateral. Retinal detachment is again occurring in 75% of the cases. So obviously it's very common. 2/3 of the patients are showing you retinal detachment, and that too within 3 months of the onset of the symptoms, secondary to the holes within the necrotic retina, or it could be in association with the vitreous traction. Now, very important thing, what all infections can cause this? So it is both your herpes zoster as well as herpes simplex can cause ARN. Most affected patients are immunocompetent. Intravenous acyclovir has been shown to induce some regression of the retinal lesion. So if you have a patient of herpes simplex or herpes zoster, it may be again involving any other symptom, and then you might be having this kind of vasculitis, hemorrhages, necrosis, and they can be giving you that the patient is immunocompetent, or then what you have to do, you can give the intravenous acyclovir. So one of the indication of intravenous acyclovir will become your ARN. Alright. Now important one is a cytomegalovirus infection. This is characterized by distended tissue cells in which nuclei contain large acidophilic inclusion bodies, and that is why it is megalo. So if you actually understand the word, then I think half of the problem is gone. Why it is cytomegalo? Because it is leading to the enlargement of the cells. So we have got distended cells, and they are containing larger inclusion bodies. The majority of the population is infected and no symptoms will be there. But in patients who are having the impaired immune function, this will manifest. So what they are trying to say, that it's not such an uncommon one, that only HIV patients will have this infection. Many and most of the patients have this CMV infection, but it is that those people who are immunodeficient will manifest the symptoms. Okay, or either it can be those who receive the organ transplants and having the massive immunosuppressive agents, or the HIV patients. The eye may be affected by an isolated macular lesion, or it can be a severe hemorrhagic, or it can be a granular retinitis. So if you remember the HIV retinopathy that we are having in the CMV retinitis, typically we have that pizza pie appearance, then we can have the brush fire appearance, we can also have the granular appearance. So all the three types can be found. Then the next in the list is your syphilis. Now if I talk about the syphilis, these syphilitic affections are usually secondary to the choroidal inflammations, right? Like if I talk about the congenital syphilis, we can have the congenital syphilis also, we can have the acquired syphilis also. So in the congenital syphilis, we can have the dusty discrete pigmentation, we can have pigmentation of the retina at the periphery where a multitude of black and white spots are there. So because in congenital syphilis we are having that pigmentation with black and white spots, that is why it is the salt and pepper retinitis. So if you again remember, what is the most important cause of the salt and pepper retinitis? One of the important thing was your congenital rubella syndrome. Then we also have the congenital syphilis. In the more definite forms, there are larger atrophic and pigmented areas. Then we have interstitial keratitis. So with respect to the congenital syphilis, I will say remember two things. One is your salt and pepper retinitis, another is your interstitial keratitis. Both are important. Now we come to the acquired one. In the acquired syphilis, we have got endarteritis, that is prominent. Then we have got the diffuse retinitis, particularly in the secondary stage. Then we also have the severe vitritis. Then we also have the atrophic optic disc. So we will have pigmentary corpuscles resembling the pigmentary retinal dystrophy. So if you learn in this way, there are certain things which will actually strike that this could be a case of acquired syphilis. We can have endarteritis, the diffuse retinitis, severe vitritis, atrophic optic disc, pigmentary retinal dystrophy. All this could be found in the acquired syphilis. The subjective symptoms are defective central vision, night blindness, irregular contraction of the field with or without central, paracentral ring scotoma, metamorphopsia. So now because you are having so many things in cases of acquired syphilis, these symptoms will correspond to these signs. If I am having a diffuse retinitis, I will have decrease of vision, I will have contraction of the visual field. Then if the pony corpuscles are there in the periphery, so I will have what you call as a night blindness because rods are affected, ring scotomas will be there. Then if the macula area is affected, then we will have the metamorphopsia, so something like this, right? Now coming to the sarcoidosis. Sarcoidosis is again an important topic for your question because it involves multiple systems and again the scope of integration is very high here. If I talk about the sarcoidosis, the characteristic histological lesion in sarcoidosis is your epithelioid cell granuloma, and this is actually very similar to the tubercle which is without the caseation. The mediastinal lymph nodes are a common site. So where you are going to get mediastinal lymph nodes? Okay, especially we have got the lungs, liver, spleen, skin and eyes together with the parotid gland are also affected. So though a common site will be your mediastinal lymph nodes, but the other areas which are involved are your so many, that is your lung, liver, spleen, skin along with the eyes. The ESR is usually elevated and leukopenia will be there. If I see the serum enzymes, so we have got the AG ratio is disturbed, then we also have the serum ACE levels, these are raised. Now ACE levels are increased, that is very typical of sarcoidosis. Mediastinal lymph nodes are again very specific. Hypercalcemia is there, tuberculin test will be negative, X-ray shows bilateral lymph node involvement in the hilar area, bones of the hand are affected, and phalanges shows the cystic areas. Now this is again a very beautiful aspect of Parsons that they have described and summed up everything about the sarcoidosis at one point. Again a large clinical scenario question could be formed from here. Person coming to you with the mediastinal lymph nodes, maybe involvement of lung, maybe involvement of lacrimal gland, maybe involvement of parotid gland, maybe involvement of any of these organs. We have got ESR elevated. Now instead of saying that it is elevated, they can give you a value, what is ESR, and but you don't have to learn them. In normal value will also be given. They can give you evidence of leukopenia, they will give you the reversal or the disturbance of the AG ratio, the ACE levels increase, chest X-ray showing you lymph node enlargement, tuberculin test negative, hence may be affected cystic areas, and they can give you the options like sarcoidosis, toxoplasmosis, syphilis, HIV, something like this, and you get a good question there. So widespread retinopathy may develop, and in the retinitis we get the candle wax drippings because we have the periphlebitis, that is we have got the inflammatory pathology in the veins of the peripheral veins of the retina, which will show you the inflammatory cells. So there will be pouring of inflammatory cells in the vitreous cavity, that is called as the candle wax drippings, and when there is a pouring of these inflammatory cells in the vitreous cavity, they will be having a collection of these cells. Collection of these cells will form the nodules, that is called as the preretinal nodules, and this sign is called as the Lender's sign. So candle wax drippings is very important. You have got the periphlebitis. So what you have, suppose this is your vitreous cavity and you have inflammation. So these inflammatory cells will be pouring in the vitreous cavity. This is called as the candlewax drippings. This will lead to the pre-retinal nodules. This leads to the pre-retinal nodules, and this pre-retinal nodules will lead to the Lander's sign. Very, very important is your Lander's sign. Now always remember that it's a granulomatous disease. So the type of inflammation that we are having is a granulomatous panuveitis. But out of this panuveitis, what is most important? That is your pars planitis. That is your pars planitis, and due to the pars planitis, what we are having? We are having vitritis. Due to the vitritis, we are having the exudation in the vitreous cavity. Exudation in the vitreous cavities are called as the snowballs or snowball opacities, and these snowball opacities will start settling at the bottom. And when they start settling at the bottom, this will be called as the snow banking. Then this will be called as the snow banking. So you have to remember, when you are having this retinal vasculitis, periphlebitis, pars planitis, snowball opacity, snow banking, pre-retinal nodules, candlewax drippings, Lander's sign, then they are very, very suggestive of the sarcoidosis along with the systemic features. Alright, now of the patients with ocular sarcoidosis, 25% show evidence of the posterior segment involvement. So how many patients, how much percentage of the patients will show you the posterior segment involvement? It is 25%, and when the retina is involved, there is often an associated affection of the central nervous system, and most of the times when I have the involvement of the retina, I will also have the involvement of CNS. Now similar to this is your toxoplasmosis and toxocariasis, and they say that toxoplasmosis will be discussed anywhere else in the systemic, so we are talking about the toxocariasis. Toxocariasis, when tissues other than skin are invaded by the nematode larvae, the condition is called as a visceral larva migrans. So here you have got two things, one is your Toxocara canis and the Toxocara cati. These are actually the roundworms, and they are the common causes of the ocular diseases. Now what is happening, most of the time the children eat the infected material, so that the eggs of the worms hatch in the duodenum, and the larvae then penetrate that intestinal wall. Now this is again you know, microbiology, you must have read the life cycle here. So when the children are eating the infected material, these eggs are hatching in the duodenum, they are penetrating the intestinal wall, they reach the venous circulation, then they go the pulmonary capillaries, and ultimately the respiratory tree. Some are again swallowed, and when they are swallowed, they again reach the jejunum. Now if the infection is heavy, children will have fever, anorexia, I'll mark it with a different color, fever, anorexia, eosinophilia and hepatomegaly, and then they are also lodging in the eye without systemic signs. Now meanwhile, this larvae will go into the eye and they will not show you any systemic signs. So larvae will produce the intraocular granulomas, which will have eosinophils, they will have IgE, which is situated centrally or peripherally in the retina as a white lesions, and it produces into the eye from the retinal tissues, and even endophthalmitis can occur. So again a very typical example where these larvae are actually lodging into the eye. Alright. Now if you see here, this is your Toxocara granuloma. Look at the fundus here, Toxocara granuloma. Now they will not expect you to diagnose the Toxocara granuloma just from the fundus. Obviously they will have to give you the related signs and symptoms, and only you can make the diagnosis. Now during the acute stage, antibody titers will obviously rise. So we will have the rising of the antibody titers, and if you do the skin test with the antigens, that will also produce a reaction. No eggs are found in the stool because no adult worms develop systemically. Now again important thing is that when they will give you a question, they will say that no eggs are found in the stool because no adult worms develop systemically. So eggs will not be there. A skin test will be carried out in order to find out the antigen, and if you test it, so testing with the larva antigens is more sensitive, as is the enzyme linked immunosorbent assay. So ELISA is obviously good, you can do the testing with the larval antigens. Vitritis may respond to the topical steroids that can be given. Along with this, we can give the thiobendazole, systemic steroids, because supportive treatment is also required. Tractional detachments of the retina are common, and obviously if the tractional detachment is there, then you will have to do the vitrectomy and scleral buckling. As far as your scaris lumbricoids are there, they can also produce ocular inflammation because of the larval migration, so we can also have that. So that's all for this session. Okay, I don't stretch the topic too long, because I know that your exams are nearby, and you cannot give a very prolonged reading. So I'm interested that you read small areas that will give you a quick insight of that particular topic, and you can move forward. Thank you, and happy ophthalmology.